Thank you, Tom, and thanks everybody. It is good to be here, and that was a nice introduction. I love your. I was going to use that as a bumper sticker. That professionals are people too, and that lawyers are people too. I also want to share with you, just sometimes. I want to share with you my daughter's description about what I do, because sometimes you do workforce policy, and I've explained it to people over. My mom still doesn't get what I do, but my daughter gets it. So for her fifth grade assignment, she had to write what her parents do for work, and she said, "My daughter Catherine works at UCSF. She studies different doctors' offices around the U.S. and tries to improve their work and health laws through reports, oral as well as written." This was one of my oral reports. And I want to go in there and correct. I want to say, well, it's not just doctors, it's all 200 plus professions in the United States, and it's not just offices, it's all the health studies. But anyway, she gets it. It's about improving their work, improving all the healthcare professionals' work in all settings, for all professions, in all states. So what I want to do briefly today, and it's going to be a hurried presentation, but I'm going to go over a little bit about workforce supply and demand, talk about education, regulation, and management of healthcare professionals within these birth settings. And then I want to conclude with what we don't know, which is actually a most important thing, I would say. So a little bit about supply. In terms of healthcare settings in the United States, physicians make up the largest supply element. Obstetricians, it's about 50,000 in the United States. Of course, there are different ways to cut all of these numbers. And I apologize, I was going to do lots of graphs with all the details, but the reality is that all of these numbers are kind of squishy. And I say that with utmost respect for dealing with all these numbers all the time, but they're all a little bit, there's gray zones. And so not all obstetricians work in labor and delivery, of course, and so every time I put out a number, there's lots of ways to qualify that information. But the largest sector of the pie in terms of professionals in birth settings would be obstetricians. And then midwives, which are composed primarily of four groups. We have the certified nurse midwives. There's about 13 to 18,000 of those total in the country, probably around, closer to 13,000 active. That 18,000 number is from the HRSA National Sample Survey, and that probably includes a number of people who are not active as nurse midwives. The certified professional midwives, about 2,000 of those in the country today. We're not sure how many licensed midwives there are, somewhere between 750 and 2,000, because not all of the states who license midwives contribute to a central database with a list or registry of those midwives. And then we have certified midwives, and that one's blank because I just found out about an hour ago that there's 77 of them. So that's the newest group in the country. So that's the breakdown. We do have some numbers on diversity, which is it's not a very diverse health professional group. It tends to be very heavily female dominated, particularly for the CNMs and the CPMs. And race ethnicity does not reflect the general population. I'll just say that. We could spend days about that. But of course, there are additional people who are involved in healthcare settings. Doctors of osteopathy, family practice physicians, the anesthesiologists who are in the hospitals, particularly for C-sections, et cetera. All of the nurses, and we'll hear more about nurse staffing in a few minutes. There are assistants in roles of doulas and others. There are all the other hospital staff, people that are on call to help out. There are interpreters. There are other people involved. And I forgot to put on my list, but it goes on and on. So the paramedics, EMTs who might be involved in a transport. There are a lot of people who are peripherally and directly involved in the care of birthing moms and their babies. And in terms of supply trends, it does vary by profession, but in all of these professions we have seen increases. And those increases vary from fairly incremental to very significant. So for example, for obstetricians, we have an increase of close to 20% over a 15-year period. So they're outpacing the population growth. It's important to know that the total number of obstetricians is outpacing. Now again, I'm sure we can get feedback on that not all of them are practicing labor and delivery, and there's lots of ways to cut these numbers, but the total numbers of obstetricians are, in terms of ratio to population, those are growing. The CPMs are also growing at a very quick rate. So those are growing at close to, what was the number that I had here, 10% per year over the past 3 years. So significantly outpacing population growth, but the N is very small, remember? So they've only got about 2,000. So a 10% growth rate still doesn't end up with a significantly larger total number. There has been a shift, as you've heard, in the number of attended births attended by midwives. So that has increased significantly from about 10%, from about 6% 10 years ago to 8 to 12%, 8% for total births, 12% for vaginal births. There are a lot of challenges to collecting these data. This is one of my main points today. So the numbers are accurate for the most part, but the challenges are it's really hard to find that information. So here I am sitting in San Francisco, and I had to start thinking, well, how am I going to get all these data? So I call my colleague downstairs, Joanne Spetz, who works on the National Survey Sample for Nurses, because she can give me the most accurate numbers on all the nurses. I returned a call from Elaine Germano, who had talked to me about their meeting earlier this week. So I called her to find out about the CNMs. I called Ida Dara, who knows about the CPMs. It's only because Ida and I worked together on the NCCA for several years. I got online, of course. I work a lot with physician workforce numbers, so I know that AMA has the data. Could connect with them. I could connect with AAMC about the workforce numbers. They're all over the place, and that's my little brain that's not very competent on any given day. But I had to pull all those pieces together just to put together 1 or 2 slides. It's not easy, and they're not standard. Those data are not standard. There's no standardized data sets across all of these. So I just want to make that point, that it's hard to find the data and they're not standard. So we can't do any comparisons, or very few comparisons and contrasts with the health professions in this field. In terms of need and demand, that goes side by side with supply. We have a fairly steady, predictable need. This is relative to many of the other health sectors. We kind of know how many babies are going to be born each year within a fairly small range. And so the birth rates are known, but we have unknown demand because we don't know really what people would choose if they had fully informed choices for and they had all the information about all the choices out there. We also don't know how demand is changing, and I'll be touching on this a little bit more at the end of my talk, but we have a lot of changes going on with the ACA. We have a lot of changes going on with the economy. People are looking at costs, not just consumers, but the people who are providing, the healthcare providers, the employers are looking at costs. Technology is changing the way we're delivering care. The market is significantly changing. We do have people who are looking at healthcare systems and looking to integrate their care. So the large systems, there's a big difference between a hospital that gets reimbursed for all of the services that they can bill for that are associated with labor and delivery, and an integrated system that is trying to lower costs for all of the costs associated with labor and delivery. That's it. Those are hugely different incentives embedded in those types of providers. Consumers, again, have shifting choices. We don't really know what people would choose, again, because most consumers don't have the full range of information available to them. And then we have some public health concerns. I am consistently concerned about the increased numbers of drug-resistant bugs in hospitals. And I am not sure what that's going to mean for labor and delivery, because right now it's the major reason, it's the biggest reason for people going into hospital is to deliver a baby. It's the highest revenue source for hospitals. But if there are significant outbreaks in drug-resistant bacterial infections in a hospital, or just a couple of high celebrity, high-profile outbreaks, we're going to have a big shift in consumer demand based on public health shifts. So I think demand is shifting, and we don't really know what the impacts are going to be. Okay, now I'm going to talk. So I did supply and demand in 2 minutes. Now I want to talk. There's a slide missing about regulation. I'll do education first. I just had it out of order. Education, you just heard a nice summary from the folks here who know much better than I do about the details. This is a brief summary up here, though, that medical doctors do have, it's a very academic program, bachelor's degree, medical school, then a residency and board certification. The model is medicine. They primarily train and practice in hospitals. CNMs, you've heard, they primarily have a master's degree program now. Many of them have doctoral degrees. They have a nursing model of care. That's significantly different from the medicine model in terms of training and practice. They do primarily practice in hospitals. CPMs have apprenticeship model or an accredited education program, as Ida explained. You can have anything from a certificate on through a doctoral degree for the CPMs. They have a midwifery model, very different from both nursing and medicine. And they work primarily in home or birth centers. And then you have the new CMs, the certified midwives, who again are very similar to the CNMs, except they don't have to have the nursing prior. All of them, and let me just point your attention to the bottom row here, have issues around sites for clinical training. It's really hard in many cases to get that clinical training site set up, particularly in anything out of a hospital setting. Big challenges in interprofessional education. I can't say enough about that. It's a lot of what my current work is focused on. We don't train people together, so they come out not knowing what each other can do, sometimes mistrusting each other, distrusting each other, and that's often rooted in the lack of interprofessional education. We have challenges preparing people based on the evidence because we still have challenges translating all the good evidence that's being produced into integrating that into the curriculum. And we don't have a real strong understanding of how to train people to work in a changing healthcare environment. The environment that people are practicing in now really doesn't look like the way most people were trained to practice 15, 20, 30 years ago. So that's challenging. So those are the big issues right now in education. In terms of regulation, so I first got into this as a law student. I had a terrific, brilliant constitutional law professor who asked me to write a paper on the regulation of midwives in California. I thought it'd be a simple little academic paper. I knew nothing about the issue. This was, way back when. And I got into it, and I was kind of astonished that we had this variation by state in practice acts. So I thought it was interesting, curious. So I started doing a lot of research, and then I ended up getting a job where we did this report on midwives, and then that expanded to doing all the other professions. But it all goes back to my little interest in midwives 20 plus years ago. So in terms of regulation in this country, we have this unusual situation where medical doctors have the same scope of practice, and they have the entire scope of practice in healthcare. They can do anything to anyone in all healthcare settings, a full standardized scope for all medical care in all 50 states, and it's pretty standardized. Midwives, not so much, nor for any of the other 200 plus professions. So certified nurse midwives, all 50 states recognize them as they can practice legally, but only 20 states have independent practice, and you can see a variation of different maps out there about whether they can practice independently, whether they can prescribe, and the maps even vary. So we can't all even agree on how to do the maps. So on some maps, you got the purples, and some maps, it's not just the colors. I mean, it's how we label all of the states, whether it's a collaborative practice requirement or a supervisory practice requirement, and it's because the laws are written by a bunch of different attorneys, for goodness sake, who use different definitions. So we come up with problems like, in some states it says, this is a collaboration model. The collaborating midwife must work with her supervising physician. So what does an attorney do with that? Do they put it in the collaboration column, or do they put it in the supervisory column? And so people make judgment calls, and that's why you end up with these different maps out there. But anyway, we have variation from state to state. So a nurse practitioner in California cannot practice the same things that they can do in California when they cross the state line over to Nevada or Arizona or anyone else. Certified professional midwives, about half of the states recognize them. So, only in half states they're legally recognized. Licensed midwives, about half states recognize also, but they're not the same half states. So that means that we have about 34 states where one or the other is legally recognized, 14 states where neither is recognized. But again, it varies tremendously. There seems to be very little rhyme or reason to it. We've tried to figure out what it is, and I can't figure it out. It's beyond my competence. And then the certified midwives, who are the newest entry to the group, about 5 states authorize their practice now. The reason behind this, again, scope of practice laws are state-based, and they're politically driven. They're not based on the evidence. And that goes back for everybody. It's for medicine, it's for nursing, it's for all the professions. They're politically driven, and they're political compromises. They result in state variability and some disconnects, it's an understatement, between competence and authority. So in some places, people are authorized to provide more than what they're competent to do. In many more cases, from my perspective, they're not allowed to provide care to the top of their competence level. It is my strong belief that exclusive scopes of practice contribute and exacerbate interprofessional tensions, and that's been touched on a little bit earlier today. It's the reality that's out there, and we do need to acknowledge it. The scope of practice battles, the turf battles, really exacerbate that problem, and people don't communicate well, and they don't know how to work together, and the scope of practice battles really make it worse, I think, because from an early age, or an early stage in one's professional development and professional training, people start hearing about these scope of practice battles at the state legislatures. They're often called upon to testify and to contribute and to write letters. So very early on, they start thinking about the others as competitors or as opponents, and I think that's a very big, huge disservice to the patients and clients today. A couple comments about management. Defining the team. We still haven't defined the team fully for birth settings. It, of course, can include the obstetricians, the nurse midwives, the doulas, all the people that were listed on those first couple of slides, but they're expanding also. The clinical team and the provider teams are changing right now as we speak. People are trying to figure out how to put together teams in new and effective ways. And we haven't quite figured out how to do that properly in all settings. As I said, we haven't trained people to work together as a team, and we don't know the impact of real teamwork, because people don't know how to work as a team yet, on workforce calculations. And by that, it's an important point I want to make, that traditionally we have all done these formulas, these calculations about how many providers to population we need, or how many we had in the past and what the trajectories are going forward. But when we put together a team of people, does that mean that we need fewer or more of the certain components that go into that team? And that's not to be taken lightly. And we're trying to figure that out in primary care. We're trying to figure it out in a number of care settings. But we just don't know yet how to calculate what the impact of a team will be on the number of people that we need to train, educate, and license. We also don't know what the impact of real team care will be on the provision of care and on patient outcomes. We're just starting to scratch the surface there. We also, of course, don't know the impact on educational programs. It will affect it. We don't know how. And we don't know the costs. And we're trying to figure that out as well. But we don't know yet what the impact of real teamness. We don't even know how to measure teamness yet. There's only a few good studies out there about teams. And we're trying to learn from the few things that are out there. But we don't know how that's going to translate to cost savings and revenue improvement for some settings. A lot still to learn. We still need accurate, comparable supply numbers. Like I said, it'd be nice to be able to do side-by-side comparisons of these different among and between the different professions, but we don't have that yet. We don't know how to measure demand yet because people don't have a fully informed range of choices available to them. So we don't know how many people would choose these different providers in different settings. We don't know the costs of various workforce and staffing models. It's just barely been touched upon in some of the research that you've heard about today, and that's really the best research that's out there. We still don't know what these things cost, and we don't know the impacts of all of the innovative practice models on the costs and outcomes. So we don't know the impacts of technology, we don't know the impacts of policy changes or consumer choice or innovative financing. So what's it going to mean when people do have ACOs, when you have various systems that are joining together and must work collaboratively as a system, so the clinic and the birthing center and the hospital and a primary care center, what is that going to mean for the impact on care? We don't know also what the, if you have a fully integrated system, it might affect the outcomes later on down the road. So for example, in an integrated system, you've got an incentive for the primary care doctor to treat the 10 or the 12-year-old, I was going to say child, it's a girl, to treat her diabetes, to treat her obesity, to treat all of these things, to treat her asthma, so that 10 or 15 years down the road, which is a short amount of time, you all know, she's going to be pregnant and hopefully not presenting with complications in her pregnancy because she's been treated with a primary care doctor or team that has been addressing her issues. And again, we don't know the impact of all of that on the workforce needs down the road. So that is where I'm going to leave it because I know I'm talking fast, but I came a long way and I want to get a lot in here today. We still have so much to learn about workforce. We still need to learn a lot about the impacts of all these innovative changes on the workforce needs and on the costs and outcomes. You can get in touch with me that way. I have lots more data, lots more opinions, lots more information to share with you if anyone's interested. So thanks for your time and attention today.
Thank you, Catherine. That was a lot to digest, and you didn't mention the word access. The North Carolina General Assembly just, 3 bills were entered, one to change the scope of practice for nurse midwives, it was based upon an argument there was not sufficient access to obstetric services in rural areas. Another thing other than demand. So we're going to talk about slightly different group of practitioners and professionals in this field with Deborah Bingham. who is a doctor of public health and a nurse, is vice president of research, education, and publications for the Association of Women's Health Obstetric and Neonatal Nurses. But I know her best as a former student who did great work when she was in class and taught me a lot. So I feel great that she's here, and I'm going to learn some more. And she's going to talk a little bit more about nurses and the team care in hospitals primarily.